This is a regular TEP approach. So I am going to make an incision at the level of umbilicus. So for that,
You don't go infraumbilical, is it?
no sir, umbilicus.
Okay.
Yes sir. Because if you use that umbilicus as incision point, you will get some extra length, few maybe a centimeter or more. That will help us in getting some extra panoramic view. And so always we go with the umbilical incision.
Do you always measure the distance between the umbilicus and suprapubic region, the symphysis?
No sir, normally we don't measure the distance. Actually we started with TAP approach and we are doing it for quite long time. Then we have moved to TEP, and from that time onwards we go through umbilicus. We don't actually normally measure the distance.
Point is, Sendhil, that if the distance is shorter than
TEP, E-TEP might be better.
Probably you should opt for
Less than 15
E-TEP
centimeters, it's considered that,
E-TEP is better, but we never had any difficulty, especially when we go through the. There are few technical points. If you adapt it, the difficulty will be brought down. So just few seconds we are getting our camera ready. Meanwhile, I'll make an incision. So what you need is an artery forceps, long artery forceps, and a retractor like this. This is the breadth of this retractor is around 1 centimeter or maybe 9 to 10 millimeter. This is like a regular Devers retractor. So this retractor is for retraction, and this artery is to open the umbilicus. So just put your instrument, open the umbilicus, start your incision from the depth of the umbilicus and extend it downward. So this is the incision which is needed. So this is skin incision around 12 millimeters in length. And now we have to expose the anterior rectus sheath. If we are dealing with a bilateral hernia and right inguinal hernia, we will go through right rectus muscle. If we are dealing with left inguinal hernia, we go through left rectus sheath. So that is how we do our dissection. So now I am just putting my instrument and opening this fat. Now I am introducing the retractor. Now we have to expose the anterior rectus sheath at the level of the umbilicus.
Sendhil,
Yeah.
sometimes umbilicus is very deep.
Very deep. Yes sir. Yes sir.
In that case also you go through this route?
Yes sir.
What about the Dulux technique? Have you tried that?
No.
For the sake of audience, I will explain. Dulux technique is that in suprapubic area, about 2 fingers above the pubic symphysis, he puts a Verey's needle, and with the feeling that he knows that he has gone through the anterior rectus sheath and not through the posterior rectus sheath, then he creates a pneumoperitoneum, extra abdominal pneumo, retrorectus pneumo. So with that pneumo, everything gets inflated, and then he takes a trocar and just puts it directly into that space because it is all inflated. That is the Dulux technique.
So he will put his Verey's needle here. He will put his Verey's needle in the suprapubic area.
And half the time he would use that Verey's needle and finish the surgery in 90% of cases.
Yes sir. So it was a 2-port hernia surgery. It was a direct hernia. He finished in around 30 minutes without even inserting the second working port. He will make a skin incision and he will put his instrument obliquely. He will feel the linea alba, and then he will pierce it. He will change the direction vertically and he will enter. He said, "Okay, I am inside." Then he will go from the preperitoneal space from the beginning itself. So you just expose the anterior rectus sheath at the level of umbilicus as high as possible, so that we will have more distance for working. I am introducing the 0-degree scope.
You don't take any stitch on the sheath to prevent any pneumo or pack in that thing with a wet gauze piece or something like that?
We used to do that initially to take a stitch on either end, cut end of the, either end of the skin, and
Yeah, now we are in a correct plane.
now we are in correct plane.
Follow the white.
Yes sir.
Follow the white. Between the 2 layers of the transverse fascia.
But then you found that without taking the stitch also there is no leak.
Yeah,
so
now,
you stopped that.
I don't normally use these stitches nowadays.
You're using 30 degree?
Now I am using 0-degree scope, sir. So you just, when you are in the areolar tissue, you are in correct plane. So,
It's a left-sided hernia, no, you said?
yes sir, yes sir.
So you are going on the left side
I'm going on to the left
or
side.
midline or only
I
midline?
am towards the midline. I want to make on port. So I am just doing wherever there is a plane, I mean there is a, I feel that the correct plane is there, I am just going forward and backward.
See, if you see the view,
Yes, sir.
the two recti are bulging.
Yes, sir.
That is the view, correct view that you are in a correct plane and the pneumo is correct. The
Correct.
two recti will bulge and the lateral wall of the abdomen will not bulge.
Yes,
That
sir.
is the correct pneumo in a
Move on to the pressure of what, 14, 12, what you do?
12, I think.
This is 14 now. You can see the inferior epigastric on the left side. You have to lift the inferior epigastric anteriorly by going, sliding the scope along the posterior rectus sheath. So now I am changing my direction. See here. So there is, this is the course of the inferior epigastric vessel. This is the, it starts from
Yeah,
here.
we
This is, you
we
can see.
We can see
Yeah,
there.
arcuate
Yeah,
line, and it is
exactly.
crossing arcuate line. It is coming up here, and this is the rectus muscle. So this is the dissection. I am trying to cross to the opposite side with the camera. I am just going forward and backward movement.
Initially, we were using the balloon dissector, but that was unnecessarily expensive thing.
Yes, sir.
So most of us have given up the dissector. Then some people started using the finger stall and tied onto the suction and then putting saline and things like this.
Yes, sir.
That also is a good technique. But if you are having good pneumo and this dissection, I think it's much simpler and much faster.
Much faster. Yes, sir. Normally from the beginning, from day one onwards, we are using these lateral ports. Only technical problem here is there is only a narrow space, there is only narrow space between the inferior epigastric and the lateral border of the rectus. So you have to enter between the inferior epigastric vessel and the lateral border, that is linea semilunaris.
The trocar come in.
It has come inside.
Suppose you make a puncture here at this stage, what would you do?
With the one instrument, I will actually limited space will be there. With one instrument, I will try to use that instrument. Preferably, I will take a scissor. I'll try to gradually increase the space with the use of camera and telescope itself. I'll use it like small instrument. So I'll go close to the plane and I'll use the scissor. I'll bring the scissor within that field. I'll try to enlarge the. If it happens at the later stage, then it will not be a problem. So if it happens initially, I will try to proceed gradually.
And steep head low helps.
Steep head low, bowel will move away and you'll have a little bit extra space.
And try to equalize it by putting a very needle intraperitoneal.
Yes.
You also will.
So if the rent is small, you can put a virus needle and empty the intraperitoneal gas. Sometimes if there is a very large rent in the post-rectus sheath followed by peritoneum, then if you put a virus needle or a trocar, so what will happen, whatever the carbon dioxide which is going into the preperitoneal space will escape into the peritoneal cavity and it will get emptied out. So you will be in fact losing the space whatever we are having. So a small rent you can use this placing intraperitoneal virus needle, but for a large defect then only the steep head down tilt which will be very useful.
So you do left side hernia also standing on the left side of the patient, is it?
Now I am just I want to create a little bit of space before moving on to the other side.
Some people put in midline port first.
Yeah.
So what is your take on that?
We always do like this on lateral ports only, camera in the midline and two lateral ports. So for that I am comfortable if I do some dissection here and move to the opposite side. We always place lateral ports. For that I have to create some space.
See, initially, Duluc also when he started,
Yes, sir.
he used to take a iliac fossa ports.
Okay, yeah.
Initially, I had been to him in 95.
Yes, sir.
That was his beginning. So very
Closer,
needle,
closer.
right side port in the right iliac fossa,
Yes, sir.
and he would finish with the very needle and the right port he would finish the surgery with.
I am crossing the midline to the, I am crossing from left to right.
Yeah, this is also good technique because from crossover becomes much simpler.
Yes, sir.
Because you're observing and your instrument is coming from below.
Yes, sir.
So creating a space on the, because you want to put another port there, isn't it?
Yes, sir.
That's
For
why-
that I am spreading, I mean actually I am trying to create a space.
Yes, I can see that.
I'll put on instrument here, knife Kurma.
So even if it is unilateral or bilateral, your port placement remains the same.
Actually, if it is a bilateral hernia, this is like a mirror image port. Lateral to the inferior epigastric, the same port. Can you show the port placement? So if it is a bilateral hernia, so this is camera. You can see about a centimeter below the maybe a 2 centimeter below the camera port. Along the linea semillonaris, I put an incision. I have entered in between the rectus muscle and the anterectus sheath. So similarly for bilateral hernia, the port will be same, something like here. For unilateral hernia, I have gone down 2-3 centimeter below and 2 to 3 centimeter onto the medial side. So this trocar will enter medial to the inferior epigastric vessels. This trocar has entered lateral to the inferior epigastric vessels. So that is the difference between the unilateral and bilateral hernia. So that our direction will be like this. It will be towards the hernial sac.
But then this creation of extra space on the opposite side in such case,
Yeah.
you will, it's a mandatory and must to fix the mesh in that case.
Yeah, if I create that amount of space only, I can manipulate the mesh in a better way. So this is the second working port.
Yes.
Okay, so I am now changing now this is going to be I am standing, now I have moved from the left side of the patient to the right side of the patient.
This lateral port concept was started by Palanivelu mainly.
Yes sir, yes sir, yes sir.
Because Duluc was talking of midline 2 ports, then you were talking of 1 midline and 1 lateral.
Yes, sir,
But
yes.
Palanivelu is the one who got the concept of 2
Lateral ports, yes, sir,
So
yes.
that triangulation is better, suturing is better.
Definitely.
Because he was suturing the mesh onto
Yes,
the.
yes,
so
sir.
With these ports, suturing is much comfortable.
Yes, definitely sir. You can see the post rectus sheath, this is this one arcuate line. I am just incising this arcuate line. I mean this is less linear semillunaris attachment. I am just incising it to enter into the lateral inguinal space. Put your instrument here. Just open up this layer. So this is the lateral space.
Yeah, with these lateral ports, it becomes much simpler.
Yes, sir. So now if I open this lateral space, then I'll have a better mesh will come nicely up. So there will not be any difficulty to bring the mesh up cranially.
You can put 15 by 15 mesh.
Yes, sir. Easily we can accommodate that large size mesh. Sir.
No, it's a good concept,
It's
you
a
know.
wonderful, very good space creation, I must compliment.
Yeah, that's why he doesn't use ETEP. He said, no, we never use ETEP.
Yes.
It is not required because your space creation is as good as or as large as ETAP.
Yes, sir. Yes, sir.
Yes, it's a good concept.
It could be called as the
sometimes
S-step.
the
Senthil, it could be called as the S-step.
Yes, sir.
No, many a times, actually, a lot of surgeons come from below upwards.
Parallel
You are going
plus
from above downwards.
Yes, sir. So this is a sac, you can appreciate the sac.
Very right.
Yes.
A sentence use in the left hand a bipolar and in right hand monopolar.
No, sir, left hand regular instrument, monopolar, this one atraumatic grasper only, sir.
No, some surgeons use a bipolar in
Yes,
the
sir,
left
yes,
hand
sir.
grasper.
Yes, sir, yes, sir.
And that also is a good concept because any major bleeding which occurs
Yes, sir.
can be easily controlled by bipolar.
Bipolar,
So
right.
it makes the field absolutely bloodless.
Yes, sir.
And the whole advantage of this surgery is that there is hardly any blood loss.
Yes, sir, definitely, sir.
At what stage do you expose the symphysis?
Actually, I don't rush to see the symphysis. Once I am comfortable with on this plane, I feel this is comfortable. I will just expanding it gradually. So automatically that will come into view. But sometimes if this, I will have see this is a,
Yeah, we can see the bone
yes,
there.
sir. So you have to cross the midline, any hernia, by if right means you have to cross onto the left side, left means you have to cross onto the right side.
Yeah, at least about a centimeter. And
Yes,
a half.
sir. Closer.
Again, a general question. You don't catheterize these patients, I'm sure.
Normally we don't catheterize, sir. This patient also was not catheterized. Closer. But sometimes if you expect a prolonged dissection, then we used to catheterize some recurrent hernias. We have done few significant number of recurrent hernias following previous lap surgery. So those areas where we expect a prolonged duration of surgery, there we catheterize, and very large hernias, of
In
course.
previously operated lap recurrent hernias which you do laparoscopically, you go in the same or you go for TAPP? in that case?
TAPPs, always TAPPs.
Usually if the patient is old, 70, 75, as a precaution we would catheterize them and take the catheter out
Yeah.
so that it doesn't happen in the ward as an emergency retention and things like this. So
Sometimes, elderly people, then they will develop retention in the post-operative ward, then we have to catheterize.
so it is better to catheterize them in the theater and then remove the catheter after 24 hours.
We'll actually discharge them with catheter and we'll remove after putting this Urimax this tablet, and we'll remove it after 5 days.
Okay.
Have you done or tried this
Center.
this surgery under regional anesthesia any time?
Sorry, surgically?
Any regional anesthesia? In the
No,
form of-
we have never tried any regional anesthesia, this one hernia person.
Okay.
Yeah.
And what is your policy for the mesh? Do you at all fix the mesh or you don't fix the mesh?
We always fix the mesh, and especially when we are dealing with a large direct hernia, we prefer to go put 1 or 2 stitches more, so that it will not bulge in the post-operative period.
Agreed.
Yes,
But in normal hernias,
Yes.
I have been following not fixing the mesh for last almost 20 years.
20,
And
okay.
I have not repented.
That's the only fear what I have is in this case, the space what you created is so big,
Yes,
so
sir.
even 15 by 15 will look small in this case and will start floating around. So you must fix it.
Yes, sir.
That
Yes,
is
sir.
what I think, looking at your dissection, it
Yes.
appears that way. But otherwise, the dissection which is made, it just puts the mesh there and it adequately fills up the entire space.
Yes, sir. Yes,
So
sir.
in that case, I think the fixation, even if you don't do, because there is no space for that mesh to move around.
Move around. Yes, sir. Yes, sir.
But in your case, I think your fixation is mandatory, I feel.
Mandatory. Yes,
Isn't
sir.
it?
Yes, definitely. So I think the content got reduced. So sometimes what you can do, you know the orientation. This is the sac. So here You know the vas difference will run medially and the gonadal vessels will run on the posterolateral side. So if there is any difficulty in encircling the sac, there is no need to keep on trying it, injuring the cord structures. What you can do, you just open the sac anteriorly. This looks like for me the actually lipoma of the cord, like I'll see it later.
Lipoma of the cord probably.
Yeah.
Sendhil,
Yes, sir.
what is your preference of taking the cord structures out from medial side or from the lateral side? Or you try lateral or medial, whichever is convenient?
I'll try on both sides, and whenever I get plain, I'll continue with that.
And you don't pull the sac down at all, I think. You will just open up and then start.
As much as possible, I'll dissect and I'll open the sac, and after that I will divide all around and then leave the distal sac.
Now even if there is a pneumo which is formed, you are not worried because the space created is very big.
Yes, sir. Antibiotic, we always give antibiotic, but and timing of antibiotic is also very important.
What antibiotic policy you use? Single dose antibiotic or what do you do?
Actually, we make sure that we are giving that antibiotic at the time of induction. Then one dose after 6 hours.
Only 2 doses, is it?
Yes, then we will give oral antibiotic for 5 days.
Why 5 days oral antibiotic? Normally 2 doses are sufficient.
Sufficient, but somehow
Extra precaution.
extra faster. I'm not able to differentiate between the sac and other structures. I'll go slowly.
Yeah, now you got that. Yes. Now you got the border. Yes. Yeah, that's the area.
This looks like the plane.
See how nicely he's advancing his grip to get the correct area. That is the thing to be observed and to be followed. That nicely he's just advancing his grip to get the better and better grip.
So this is the sac. So this is what I am telling. Sometimes there is any difficulty, no need to continue with that. This one. You see, I know this is the sac. So what I will do, I will catch this end. I know where the vas is going to come. It's a bit thick sac because of chronic this one.
Yeah, it's a chronic hernia.
Yes, sir.
The sac is very thick.
Very thick. So now,
Do you do anything to take care of the smoke which gets created in during this surgery?
sister,
Any particular tips?
actually sister is gradually evacuating the smoke gradually. Now, even without we telling, they will evacuate gradually in a balanced manner. We should not we should not lose the pneumoperitoneum, and continuously there will be a minute flow of this one outside. So you dissect it like this, and then apply diathermy for few millimeters. Then catch hold of this sac. Introduce your instrument.
Sendhil, this is a very good way to dissect the sac.
Yes, sir.
Nice.
Thank you, sir. So like this, now I can understand. I have got only this amount of dissection left over. So I will advance it further. I will hold it like this, and I will introduce the instrument like this, and then apply a little bit of diathermy. So this is the way we should dissect the.
Sendhil, is it your original idea or somebody else's idea? What is it?
This one is our own idea, sir.
Yeah, I thought as much.
Yes, sir.
So we can call it as Sendhil's way of doing hernia surgery. Yes.
Yes.
No, it is a nice technique. We must appreciate.
No, we
Very
must
good.
appreciate that without struggling much.
Yes, sir.
That way you start
So
dissecting.
this is the way we can manage the thicker sacs.
Yes, exactly, and chronic hernias.
You can see, sir, we have divided all around.
Yes.
So
Yes, yes.
we are divided all. Now our this one is just give a nice traction. See, automatically this will move away. So again, change your grip, give nice traction. Very brief diathermy, very minimum diathermy on the sac.
You are still on the 0 degree only, I suppose, no?
Yeah, we actually initially we used to change it to 30 degree once after placing the ports. But nowadays we continue with 0 degree and complete the surgery with 0 degree. So basically, the idea is to strip the peritoneum and place the mesa. That's it. That is the aim of any hernia surgery. So see, now I am not worried whether the sac is completely open for nearly. So I am not worried about that, because I am not going to. Once the dissection of this amount is done, then this pneumoperitoneum will not cause any issue. So now I will leave it here, then catch it here. So these are, you just spread it like this. So gradually the peritoneum is moving away.